I'm Thomas Baldrick at ASCO 2015 for Oncology TV. Happy to have with us Dr. Marcia Brose from the University of Pennsylvania. You're a very busy woman. Thanks for stopping by.
Thanks.
All right, let's talk about this other phase 2 study you have.
Okay, so we're presenting for the first time the results of our phase 2 study where we studied the effects of adding Everolimus to patients who have progressed on Sorafenib alone. As you may be aware, about 2 to 3 years ago, the first FDA approval in differentiated thyroid cancer for patients who had progressed after radioactive iodine was Sorafenib. So Sorafenib was approved just over a year and a half ago. And at that time, we had a lot of patients who did very well, and some patients do well sometimes for a year, sometimes longer. But the problem is that these patients have a very, very good performance status, and when they start to progress, they need other therapies. So we did some work in our lab and found out that patients who were more likely to progress had upregulation of the phospho-AKT pathway. And so based on this, we wanted to add in an inhibitor of that downstream pathway. So we chose Everolimus, which is an mTOR inhibitor. Now, previously it had been concerned that they were too toxic to add together. So we had an intrapatient dose escalation to see how high a dose we could get. And the limiting dose in the past had been due to hand-foot skin reaction that got too bad. Well, so the design is basically patients at the time they progress on Sorafenib, they stay on the Sorafenib, and then we add in Everolimus, and it was a 35-patient trial.
So what did you find in terms of toxicity and results?
Okay, so first I'll say toxicity was a big surprise. It was actually very tolerable. We had many patients, almost half, were able to get to full dose of both drugs. And the reason we discovered was that by the time they actually add in the Everolimus, the hand-foot skin reaction is already well controlled, the patient is acclimated to it. So a large number of our patients were able to get either a full dose of both or a full dose of Everolimus and 600 milligrams a day of Sorafenib. So first of all, it was very well tolerated. Almost all, not quite all, but the vast majority of toxicities were all grade 1 and 2, very few grade 3 and 4 toxicities, and well tolerated. And the results that we presented today are showing that we've met our primary endpoint. The null hypothesis is that once people start progressing, they progress about 20% within about 4 months. And we reached our primary endpoint. Our progression-free survival was 13.9 months. So that basically says that at the time a patient progresses on Sorafenib, if you add in Everolimus at that point, on average, you can expect to get another year or over by adding in that second agent. Interestingly, we had some patients who went out as much as 3.5 years, and they may have only gotten a benefit of Sorafenib for a year, but then they went for 3.5 years more than that. So just between Sorafenib and then adding in Everolimus, we could keep people stable for a good long period. And so it's a positive trial. It's a very manageable regimen, and I think it could be one of the possibilities for second-line care for patients in this population.
So how might you build on these pleasant surprises, if you will?
Well, I think that the pleasant surprise is that, Everolimus might actually work when you give it after a VEGF receptor inhibitor. It might actually be what I consider a VEGF inhibitor extender. And so there may be other chances where people wanted to combine those two therapies and they couldn't do it because they added them both at the same time. So the first thing is, if you're in another cancer and you want to combine them, maybe you should do a sequential step-in approach as opposed to starting them both together. So that could be applied to other cancers. And in the case of thyroid cancer, we may actually start to have this situation where we have these 2 FDA-approved drugs, but maybe what we'll do is we'll add in between them a step where we have the FDA-approved drug, say Sorafenib, and then add in Everolimus, and then when they progress on that, go to the second FDA-approved drug, Lenvatinib, and then we're actually going to do a trial now where we do the same sort of approach where we add in Everolimus to Lenvatinib. And so maybe we'll be able to see that we have the same effect in that setting as well. And what's more, we also have anaplastic and medullary thyroid cancer patients that tend to have a little bit more aggressive tumors. So doing a combination of a VEGF receptor inhibitor and Everolimus may be a way to go forward in some of those tumors with a little bit more resistant disease.
Nice work. Keep plugging along.
Thanks.
Thanks for sharing, and we'll see you again soon.
Okay, see you next year.
You got it.